This is placeholder media that you'll see if you add a layout to an empty scene. You can go ahead and delete it.
Thanks for joining us on the Joint Replacement Podcast. I'm pleased to have Joshua Rozell, Associate Professor of Orthopedic Surgery in the Division of Hip and Knee Reconstruction at New York University Langone. He serves as Associate Program Director of the Residency Program and Chief of Orthopedics at NYU Langone, Brooklyn. Thanks for coming and joining us on the show. You're officially our first visitor to the podcast.
Thanks for having me.
Josh. Yeah, absolutely. We go back. We did residency together. Josh was my senior resident and always a great teacher. And I think he's renowned at NYU for teaching the residents and a great educator. So I just want to jump in and have you tell us a little bit about your practice at NYU.
Yeah, I've been in practice about 6.5 years. And my practice is primarily hip and knee arthroplasty. I do about 20% revisions. And all of my primary arthroplasty cases are done robotically using the robotic system. And I do about a little over 500 cases a year, about 550 cases. And I do some trauma call as well. And I see patients in both Manhattan and Brooklyn. So I have two separate kind of practices, very diverse patient population at NYU. And because it's a very large academic center, we have the largest residency program in the country. We've got 72, soon to be 16 residents a year, and we've got 5 clinical fellows as well. So we've got a lot of trainees and a lot of minds to mold as they become orthopedic surgeons. So it's a great experience there.
Yeah, that's incredible. So you have a lot of exposure to the trainees. Just jump back to your history. Do you mind just telling the folks what made you decide to specialize in hip and knee replacement?
Yeah, I was undecided in residency initially, and then I still remember it was one of these pivotal moments. I was thinking about going into trauma, and then we were sitting in the call room at 3 or 4 o'clock on a Friday, and we were finished with the day, about ready to go home, and then an open fracture came in, and the attending said, "Oh, well, let's just add it on." And then my Friday night got delayed a little bit, and for me and my personality, I think the predictability of arthroplasty is really what kind of speaks to me, and the opportunity to develop a very specific set of skills that can be honed over time and reproducibly really aligns with my character and how I practice surgery. For me, that was the tipping point. I wanted a little bit more of a predictable practice and the ability to really fine-tune my skills to improve patients' quality of life.
Yeah, absolutely. And for patients who may not know, trauma, you have to operate all over the body. So when we're on call, we might be operating on a humerus or an ankle or something like that. But with hip and knee arthroplasty, we have 2 real surgeries, hip and knee replacement, and you get a lot of practice, especially when you're high volume like yourself.
Yeah, and I would say some people might think, oh, no, it's only 2 surgeries. Doesn't that get boring? And I think there's a couple of answers to that question. On the surface, it might get monotonous, but really every patient has a unique personality to their knee or their hip, and there's always these very subtle differences from case to case. And I find that there's always a new challenge. There's always something that comes up that I may not have even seen before. And there really is quite a bit of variety, especially as you get into the more complex stuff, and then certainly the revision cases.
Yeah, that complexity does keep it interesting. I think doing only hip and knee replacement, you notice the subtleties more than if you're a little bit more of a generalist and you have to treat everything the same. Yep. I think even more than the complex cases where you go into it with a plan A, B, and C and you have backup options, sometimes you run into a case that you think is going to be bread and butter and it's completely unstable and you weren't really expecting it, and then on the fly you have to figure out exactly what you're going to do with it. So having that background is nice.
Yeah, it's certainly humbling. You can do 100 cases and 99 of them go really well, and then the 100th case, you're like, oh, this is really tough. So no matter how far along you are in practice, always be humble.
Yeah. And for folks who might be interested in becoming a joint replacement surgeon someday, or just want to know what the path is, what does it take to become a joint replacement surgeon?
Yeah, there's a common pathway initially. You're 4 years of medical school, and then you do your orthopedic surgery residency, which is 5 years. And there you're doing all different sorts of rotations, trauma, foot and ankle, tumor, pediatrics, really getting exposed to all the fields so that when you graduate from residency after those 5 years, You can, when you pass the boards, theoretically, you can practice as a general orthopedic surgeon. But I would say most residents today are doing fellowships, which is even more subspecialized training. In you can do it in any one of those fields, or some people are even doing two fellowships, and those are all 1 year long. And then after that is when you start looking for jobs as an attending, either academics, private practice, hospital employed. There's a whole different variety of practice models.
And what do you get in fellowship that you didn't get in residency, or what are people looking for?
Yeah, I think when you graduate residency, you are pretty confident. You think, oh, I can do this. This is pretty good. I'm really confident. And then you get to fellowship and you start to realize, oh, the way I was doing it isn't really the only way to do it. And I'm learning all these different little things that I thought I might have known, but now it's a completely different perspective. So I think you again get very humbled. So your confidence gets brought down. And then you spend the year doing just hip and knee replacement, and your confidence goes back up by the end of the year, and you're ready to go. You're ready to be an attending. And then you start as an attending, and there's nobody looking over your shoulder telling you, "Oh, this is right. This looks okay." And then you have this sort of impasse where you think you don't really know anything anymore until you can spend the time being an attending and really getting your confidence and getting comfortable operating by yourself. So it's this sort of emotional roller coaster between all your levels of training where you feel confident at certain points and then very humbled at other points. And I think over time, you really just become, like anything else, better at your craft. And it takes several years once you start practice to really have a good sense of how you are as a surgeon and your tendencies. So it's lifelong learning.
What is your philosophy when deciding who should have a joint replacement?
While I am a surgeon and I love operating, I think it's important to understand that having a joint replacement is really a very subjective decision that the patient has to make for themselves. We can certainly show them the x-rays and show them that they have deformity or they can't fully straighten their leg or bend their leg. But ultimately, they're really the ones that have to decide if it's the right time for them based on their pain, their quality of life, and their function. What I like to tell patients is if you were my family member, I would tell you to live with it for as long as you can. And when you feel like you can't do the things you like to do or your quality of life is suffering, that's when you start thinking about having surgery. And I think putting it in their court and having them make the decision really adds to the shared decision making between you as the surgeon and them as the patient because they feel like they're contributing to their overall care and they're making the decision for themselves. And we're just guiding them and educating them about the process. But ultimately, I think for this type of elective surgery, it's ultimately up to the patient to decide when that time is right for them.
I have a very similar conversation with my patients.
It's funny, throughout all these years of training, we have all these different mentors that have different spiels and they all say different things, these one-liners to patients. And you start to see that you have a repository of everything that everybody's ever taught you, and you're using lines that you thought were very corny that you're attending, you're just using in residency or something, and then you're doing the same thing. So it's funny to have all these different mentors that are contributing to how your practice has formed.
What do you think separates a good joint replacement surgeon from a great joint replacement surgeon?
Yeah, good question. I think in order to be a good surgeon, you certainly have to do the volume. That's the first part. You're not going to get good at something unless you do a lot of it. I think you have to have the volume and the experience to see all the different types of things that could go wrong and how to fix them and how to troubleshoot and go from plan A to B to C seamlessly. So that's the first part. I think obviously it takes some technical acumen and the ability to realize that you can always be better and never being satisfied with your current level of skill or knowledge or ability. And then I think it's just this relentless pursuit of excellence. It's this constant yearning to be better and never complacent, right? Every single case, from putting the drapes on to putting the ioband to making the incision, every little step matters. And the second you let up on that and you think, you know what, I'll just cut this corner or I'll get by doing it this way, things start
Yeah.
to fall apart. So I think it's just a constant, relentless pursuit of excellence that really makes a great surgeon.
The next few questions are questions we hear commonly from patients, and I just want to get your take on it. I know
Sure.
I've given a couple podcast talks on my view, but they always say you go to 5 orthopedic surgeons, you get 7 opinions. So I
Exactly.
just want to run some of these by you.
Yeah, sure.
What do you tell your patients as far as how long does a joint replacement last?
I tell them that with the current implants, we expect your joint replacement to last multiple decades. Certainly, it's a mechanical device, so the more you wear on it, the faster it is to wear out. But that being said, we have data now up to 20, 25 years that show very good outcomes with these implants. So if you take care of it, it's going to take care of you. And that includes things like low impact exercise, stationary bikes, swimming, and avoiding things like signing up for marathons and doing very high impact type activities. And the fact is, we're getting patients who are younger and younger who want to be very active. So I think that we've had to adapt our conversations a little bit. And we've got some new improvements in some of the implants that we use that can help increase the longevity of these implants in these younger patients.
So what do you do with the patient that tells you that they want to get back to running? That's why they want to have the surgery. What do
Yeah.
you go over with them?
Yeah, again, I try to paint a realistic picture for them. Can I stop somebody from running completely? No. But I tell them, don't, you should try to avoid long distance running. If you need to run to save your life or run to catch the bus or do a light jog, that's okay. But I wouldn't run 20 miles a week. And I think people tend to understand that. And I try to go over some other activities that they can do, stationary bike or road biking, elliptical, some cross training type activities, hiking, things that are a little bit lower impact that can also give you the same cardiovascular benefits. I try to discourage patients from running, and I even tell them that running is not good for a non-replaced knee or a non-arthritic knee, and just the same as it is for a replaced knee. I tend to try to steer them away, but obviously patients are going to ultimately do whatever they want to do and what's within their abilities.
Yeah, it's in some ways our job to just tell them what the risks are, and ultimately they're going to be the ones making the decision.
I think that this is the one question that you really have to be honest with patients about. You paint this picture of, oh, you're going to be able to get back to your activities and enjoy your life. But I think being very realistic about how painful this surgery is very important, because patients hear that they're going to get back to their functioning and all of a sudden everything else goes out the window. I have a very honest conversation with patients and I say, look, for the first 2 weeks, you're really not going to like me. It's going to be pretty painful, manageable and tolerable, but it's not comfortable. I tell patients they're going to have a problem sleeping at night. It's going to be swollen. It's going to be sore. They may have some bruising up and down the leg, but all that's temporary and it goes away with time. But you just have to fight through that for the first couple of weeks, and then things start to improve. And we've done a lot of things with multimodal pain protocols and preoperative cryoablation that have all attempted to help improve that pain after surgery. But the fact of the matter is, this is maximally invasive, painful surgery, and it just takes time to improve. I tell people that most of the recovery takes place within the first 3 months, but people continue to make progress even out to 1 year. Even if patients come back to the office at 4, 5, 6 months and say, hey, you know what, I still feel like I can't do stairs properly, or I still get pain at night. I tell them, just, you got to stick with it. You got to keep it moving, keep doing the exercises, ice it a lot, and eventually you can turn a corner. But it's a painful surgery. It's much different than a hip replacement.
And when do you tell patients, we were talking a little bit about patients who want to do running or higher impact activities, when do you tell patients that you expect they'll be able to return to regular sport, low impact sports and exercise?
So for the first 6 weeks, I try to slow them down a lot, just light walks around the house. They can start going outside. But again, those first few weeks are critical, because the more you do, the more it's going to swell and get inflamed. So I tell them to tone it down for the first few weeks. And then by 6 weeks, we get them back on a stationary bike. And 3 months, I say, for going back to full activity. We started doing this quiet knee protocol at NYU, where for the first 2 weeks, we have a set list of exercises they can do. We don't want them walking more than 1,500 steps a day, a lot of icing, no real physical therapy. It's just let everything cool off for the first couple of weeks. So we stopped sending physical therapists to the house. We stopped sending home nurses. And really, patients are just doing their own thing for the first couple of weeks. And the naysayers might think, oh, they're going to get very stiff over those first 2 weeks. But I think we really haven't seen that since we've started doing this. And I think that the people who push it too early are the ones who are going to get more inflamed and then eventually more pain and ultimately lead to stiffness. So we really haven't seen an increase in the rate of manipulation, even with this quiet knee protocol. So it's been very effective, I think.
Was that started at NYU? Or
there are a couple other centers that are doing it. HSS is doing it as well. I think as we are moving into these different alternative payment models where we're really trying to contain costs that are potentially unnecessary or not effective, we really need to think about what we're doing for these patients after surgery. We want to obviously send them home, and we want to give them the resources that they need to be successful, but we want to make sure that they're not actually doing themselves a disservice by doing too much too soon. While we're not sending patients home with physical therapy, we are increasing the touch points between the care team and the patient. We're calling them, we're sending them messages to see how they're doing, we're being in touch more. And I think patients really feel like a strong connection with the team. Ultimately, after having the surgery like this, even if you have support at home, you still want to be able to be connected to your surgeon. And the ability, social media and electronic medical records and all this stuff has really enabled us to be in close contact with people. They can send us pictures, they can send us messages, things like that, and we can always give them a call back or something to make sure they're doing okay. But that connection is really important.
That's great. What do you feel is the biggest mistake that some patients make after surgery?
Biggest mistake people make after surgery? I don't necessarily know if it's a mistake, but I think that having unrealistic expectations about the recovery is probably the biggest thing that I see. And I think that,
Hmm.
like I said, it's a painful surgery. It takes time to recover, and you have these people who really just want to get the surgery and run out of the hospital and get back to their normal activities, and that's really just not the case. And the fact of the matter is, the updated data shows there's about a 5 to 10% chance that patients are going to be dissatisfied with their knee. I think that's improved over time, but there's always going to be a subset of patients that are not truly satisfied. And I always tell patients, we're not giving you the knee that God gave you, but we try to get it pretty close. And you'll always know you have a knee replacement. It's not going to feel completely natural. We're still taking out your ACL, we're still taking out your meniscus, and it's just a different knee. And the knee is a very fussy joint. The hip is a little bit different, but a
Yeah.
knee can really be challenging. And I think just having unrealistic expectations about the recovery is something that patients often fall into that can lead to higher rates of dissatisfaction.
Are there certain innovations in joint replacement that you're really excited about?
Yeah, about 3 years ago, I started using a robotic system for all my joint replacements. And I think that the main advantages are number one, I think it really makes everything a lot more precise and a lot more accurate. Before we were using all these manual jigs and instruments and just, for lack of a better word, just eyeballing everything. And it seemed like everybody was following this cookie cutter approach. Everybody got the same cuts and the same this. And so with robotics, we're really able to dial in accuracy and precision to within a half a degree or a half a millimeter. And I think on that token, it's also allowed me to do a lot less soft tissue dissection. If I'm able to manipulate the implants very subtly, I'm able to match the patient's native knee soft tissue envelope and personality without having to really adjust too much else. And I think that that really contributes to decreased pain, improved function, and a better sense of feeling like it's a natural knee. So I think that's been a huge innovation in joint replacement in particular is the use of robotic technology. I think another important innovation has been the use of cementless implants. And traditionally, for the past 75 years, we've been cementing these implants in place. And over the last decade or so, it's become apparent with 3D printing, with the introduction of these porous metal components, that you can get implants to basically grow onto somebody's skeleton. And if that happens, then there's really a very low chance that the implant can loosen over time. And we were talking before a little bit about longevity and how long these implants last. I think if you can do a very
Yeah.
precise surgery with a robot and make perfect cuts and get the implant to sit exactly how you want it, I think the bone quality is appropriate for a cementless implant. I think it's a home run. So I think those two things have really revolutionized the surgical component. And then a lot of things regarding the post-op care, things like multimodal pain protocol, different anesthesia techniques, preoperative cryoablation, all of these perioperative measures that surround the surgery are very important in making sure that patients recover appropriately.
Any idea of innovations you can anticipate might be coming to joint replacement in the next 10 to 20 years that we don't have yet?
I still think we haven't quite figured out the perfect knee implant. Implants have been around for a while, and there's literally hundreds of designs. And I think the reason for that is because we don't quite know which one is the perfect one. So I think there's more to be done in terms of understanding the biomechanics of the native knee and the patient's alignment and things like that. So that's something that can be improved upon a little bit. We've done a lot with the plastic articulation bearing. There's been different ones that have come to market to try to mimic the native kinematics of the knee. And that's been very powerful in improving patient outcomes and patient function. Additionally, I think that remote patient monitoring is going to become more and more important. being able to have certain wearables or temporary tattoos or actual changes to the implant that allow you to monitor patients in real time for range of motion, for pain, for things like that will be very beneficial in helping patients achieve the best outcome. And again, not so much with the primary knee replacements, but we really haven't solved infection over the many years that we've been researching it. And I think that there's a lot more innovation that can be done in the field of infection, because certainly that's the arthroplasty surgeon's most dreaded complication is you do this great surgery, you hope they have a great outcome, and then an infection, which happens about 1% of the time, about on average, can really be very devastating for the patient. Even though it doesn't happen frequently, when it does happen, it's really catastrophic for the patient and for the surgeon. Trying to figure out ways to mitigate risk of infection, I think, will be very critical moving forward.
I'm just going to ask a few rapid fire type questions, get what your preference is in your practice. But you actually were just mentioning this, but cemented or cementless implants?
Yeah, I do about 30% cementless, and it's really a game time decision for me. I take into account the age of the patient and the bone quality. So if I'm in there and I think I'm going to do cementless, but the bone quality isn't great, I'll just cement it. So it's really more of an intraoperative decision once I get a sense of the bone quality. But I try to do it as much as I can.
Do you have an age cutoff where you wouldn't use cementless, or it really is based on the bone?
I would say it's primarily based on the bone. I get a little bit weary about females over 75, but there are some studies that show that even those patients do well with cementless implants. But I think it's important, like with anything and any decision you're making surgically, is to not be completely dogmatic and say everybody has to have this or everybody has to have that. It's a patient by patient decision.
Posterior or anterior hip approach?
I do 100% anterior for my primary hip surgery, for my primary hip replacements.
And most important factor for a good outcome in a patient?
I think from a surgical standpoint, I think that the most important factors are an expedient and efficient surgery. So getting the patient on and off the table in a short amount of time, but doing a very effective surgery. Getting the wound closed and respecting the soft tissues, I think, is critical. And then again, I think patient expectations matters a lot for functional outcomes. As patient-reported outcomes are becoming more and more important, we're seeing that if you indicate a patient for a joint replacement who has a preoperative KOOS-JR or HOOS-JR score that's above 70, it's unlikely that you're going to really have a tremendous impact on their quality of life because they're already pretty high functioning, because they have a very high preoperative functional score. But if you take somebody who has a preoperative KOOS-JR of 20 and you increase it to 60, that's a dramatic change in their quality of life. So as people become more functional even before surgery, I think the window becomes narrower and narrower to really have a tremendous or very noticeable impact on their quality of life and their improved function.
And just for patients, average HOOS or KOOS at 1 year after surgery is about 85, which means minimal pain with few activities. So a 70 would be pretty good, 50 and below would be pretty poor functioning, a lot of pain with most activities. Inpatient or outpatient surgery?
I would say most of the surgery is outpatient. We are at NYU, we are building, there's 4 surgery centers under construction right now, opening next year. That being said, I do about 25 to 30% same day discharge, a little bit more for hips than knees, and a little bit more in Manhattan than in Brooklyn. But again, that has a lot to do with patient housing situations. A lot of the patients in Brooklyn have 4-floor walk-ups and they live alone, and it's very challenging for somebody like that to go home the same day. And then I have some patients who are relatively sick with multiple medical issues and things that are difficult to control. Keeping those patients in the hospital around the perioperative period can be very important. But I would still say that most of the patients go home on post-op day 1, and a smattering of patients will go home post-op day 2 or 3, depending on their situation.
And what advice would you give to a patient who is nervous about having surgery?
Yeah, I would say that it's totally normal to be nervous about having surgery. It's still an operation, it's still a recovery, so there's definitely things to be nervous about. But I think having a good relationship with your surgeon who understands you and understands where you're coming from and can explain things to you in a way that you understand can really make the difference in forming a partnership that can be very effective for your long-term recovery.
That's great. Thanks so much for joining.
It was a
Appreciate
pleasure.
it.
Thanks for having me.
And yeah, thanks for all you do, and we hope to chat with you again in the future.
Take care.